All right, we were working on the lovely world of rheumatoid arthritis. On my online videos or PowerPoint things that are voiced that I post, it'll say like RA1, RA2, like the first part of the lecture that whenever at every break I try and turn it off and start a new one. So sometimes because of where breaks fall, some of them end up being really short, some are longer. I'm sorry, you'll just have to deal with that, I guess. Can you hear me? We okay? Yay, okay. All right. I'm not a big mic fan, but I can walk around this way, though, and not have to stay close. All right, so again, teaching is a large portion of what the RN does, so making sure the patient understands their disease and how to avoid exacerbations. When they're inflamed, you don't want to put any weight on those joints. When the joints are acutely inflamed, you don't want to weight bear on them. You want to avoid heat. We talked about that. You do range of motion. Minimally, you want to rest it. So you can move a little bit, but not a lot, right? Persistent pain makes the patient not understand pain management because it's like, but I always hurt. There's a difference between the day in, day out stiffness and aches and the flare pain. And having them understand that and understand the pain management difference and what they have to do during different times is really helpful to keep them off of opioids and things like that. Are opioids going to treat pain? Yes. But are they going to treat inflammation? And it's really important to treat underlying cause here because the cause is causing the destruction, which is causing the pain. So they'll end up doing all kinds of non-traditional stuff too, right? Patients try all kinds of stuff when they're in pain. They're desperate. All right. If you're fatigued, we want to help them get a nice, good sleep at night. So sometimes a warm bath or shower before bed can help relax. Teaching them relaxation exercises because a good 7 or 8 hours of sleep at night becomes very important when you're inflamed. So if they've had a lot of activity, like they've done something big, then they need to take a while and rest afterwards, do some good recovery. Teach them time management so they don't feel stressed and out of sorts. What else? Exercise. We talk about exercise all the time. And proper nutrition. Because of the anemia, keeping them on iron, keeping them on vitamins and things that help build blood cells is very important. Protein levels is going to be important in general. We have to build healthy tissue and red cells. And white cells. Let's see. Relieving pain is fatiguing. So if you're in pain, even if you haven't done anything, you feel tired. I don't know if you've noticed that. If you have a headache, you're just like, I just can't do anything. It hurts. Or that kind of stuff makes you more fatigued. So getting them up and moving is easiest if we can manage their pain. Because who wants to get out and go exercise today if you hurt everywhere? So devices and slims can help with the fatigue because they give support to the joint. We talked about time management a minute ago. All right, what else? We want to refer them to a good physical and occupational therapist as they have ongoing problems. What's an occupational therapist going to do that's different from a physical therapist? Small bones and muscles. Physical therapists do large bones and muscles. You're right, though. You said they're going to teach you how to do daily living things. Writing a check, right? That's small bones and muscles. Holding a purse, cleaning something up, getting things. Whereas large muscles are walking and balance and bending, stooping, moving. But so small and large muscle and bone groups, that's really their biggest difference. The occupational therapist will teach you how to get on the bus and put the money in the slot and ride the bus if you can't drive. The physical therapist will teach you how to get out of your house to get to the bus stop, ambulate there. Okay. So getting them their proper footwear is really important too. They're going to need lots of support. They're going to have pain in their ankles and feet. And so getting things that don't rub, don't pinch, don't cause hammer toe or bunions and things are going to be really important. Aerobic exercise and a warm pool, how wonderful would that be? This time of year, I don't even know if I want to get in a warm pool this time of year. I'm afraid, probably getting a pool is not being in the warm water. It's when you get out in the winter, right, and you're freezing. Okay. So flexibility and strength programs, obviously, and a lot of this is repetition from the things I've said over and over and over today. Simplify your workflow. It's hard sometimes that's just organizational things, getting things organized in the right place. They have trouble with things that we don't think about. Like, I don't know what kind of purse you carry. I have one with straps, but a lot of women carry clutch purses. Well, if you have RA, holding that all day while you go shopping and everything, that's going to really hurt your joints, right? Or other things that you just, like carrying a notebook or a tablet around. I mean, you use these joints to carry that, right? So it's those kinds of things may cause them great difficulty. So keeping them positioned well with an adaptive device, a carrying device attached to it, can really be helpful. Having grabbers so they can pick things up easily off the floor rather than, so they can just squeeze rather than fine motor movements. If we're during an inflammation, keep their joints in a neutral position. Teach them to use as much as possible their large muscle groups. Tell them to change positions frequently, bless you. Patients with RA have trouble with repetitive movements. So typing and keyboarding, is that repetitive? Texting, repetitive movements, right? Holding a cell phone and texting is hard for an RA person, especially in today's world. For how often do you hold your cell phone? Pretty much 12 hours a day, right? Okay, at home, things that require this movement, you're going to need adaptive devices on. So what requires this movement? Jars? Door handles, right, absolutely. So the handles that push down can be replaced in your house. You can get jar opening, like little things that open jars. All right. It seems so simple that,
The faucet.
Faucets, yeah, you can have lever faucets rather than twisting faucets. So the decreased mobility leads to problems in self-concept. It also is going to hurt your safety, because safety relies that you move quickly and able to manipulate stuff quickly, right? Dealing with a house fire, dealing with you drop something in the bed, like smoking in the bed. Don't do that ever. But if they did and it drops in the bed, it requires speed of movement to get away from that to avoid burns, right? If you're imbalanced in your gait and you have electrical wires or throw rugs and things around that aren't well secured and out of the way, things like that. All right. So you want to talk to this person and know how their mood and affect, their emotional status is doing. All patients, I'm going to say this over and over today, all patients with this chronic illness have problems with depression. They're high risk for problems with depression. So we are always assessing that in these patients. And we always ask a lot of questions about their self-image, their self-esteem, and how they feel about their mood. Because it's not, people commit suicide for a lot of reasons, right? Mostly a depressed mood, which we're going to talk about this afternoon. But you get depressed mood from, I don't know, it could be an emotional breakup, it could be lots of loss, or it could be chronic pain and illness where you feel like it's hopeless, and there's no future that's bright, that's always going to hurt. So we have to keep that team going, give them a support system, constantly reassess it. And would we use mood stabilizers and antidepressants if we need to? Absolutely. Absolutely. You know, just because you're on an anti-inflammatory doesn't mean you can't take a tricyclic antidepressant. We can't say, oh, it's going to get better when the flare is over, you're not going to hurt anymore, because yes, they're still going to hurt, it's just going to be different pain. And make sure they have a good support system and know where the resources are. Teach them other ways of doing tasks. That's on this screen. Elevated toilet seats. Y'all know what I mean by those? Things that sit up? Because squatting and moving, that takes a lot of ankle and knee movement. So if you don't have to bend as much, it can be very helpful. Velcro rather than buttons. Think about buttoning a shirt and how much finger action that is. So getting things that are Velcroed or slip-ons over the head, right? Things less finger and hand movement. Buttoning jeans, that can be tough on fingers, so having elastic waists, right? Adaptation. Keeping their weight down. We talked about obesity being a factor that could increase their flares. It also puts more stress on their joints, makes them more likely to develop RA to begin with. So keeping their weight down. Foods that are rich in antioxidants. What is an antioxidant?
something that keeps bad cells from growing?
Reduces oxidative stress.
Yeah, it destroys free radicals.
You're right. Okay. I know, we're like, I don't know, we hear it all the time. We've been talking about it for years, so we're going to teach our patients to eat antioxidants. In our body, oxygen chemistry, right? H2O. That's two hydrogens bound to an oxygen. That's a molecule, right? We also have oxygen that runs around the body as O2. That's like, we want that. It lives in our body. We breathe it in. It connects to our heme group and makes ATP, right? We like oxygen. It's a good thing. But oxygen that's not bound to another oxygen or a hydrogen can be problematic. A single lone oxygen molecule is an oxidant. It's another name for that is a free radical. How many of you have heard that free radicals cause aging and joint destruction? It does. And cancer. Absolutely cancer. We're going to do that in a few weeks. And we'll have this conversation again, but not exactly. I'll try to remember. So if you've got a free oxygen running around, 70% of your body is H2O. And that free oxygen goes, ooh, look, there's an H2O. I do want to bind to something. I'm going to bind to that. Now I have H2O2. What is that?
That's hydrogen peroxide.
Hydrogen peroxide. Hydrogen peroxide is shown to destroy tissue. So free radicals increase tissue destruction and age you. So we give you antioxidants to fight those free radicals and those extra oxygen molecules, right? So what's a free radical? What's an antioxidant? Vitamin C. Elderberries. Vitamin E. Your vitamins are a lot of antioxidants. Elderberries, very much. You're right. Elderberries we don't do a lot of in the States. That's a real European. It's really good. You can buy elderberries.
It is making its way.
It is. Yes, I'm starting to see it here. It hasn't been common. It's a lot more popular on the East Coast than it is here. We're getting it. Okay.
It's not healthy for a lot of bodies.
Okay. Specialized eating utensils, omega-3 fatty acids like fish. We're going to have our salmon. Not all fishes, but our red, thick fishes that are high in fats. Salmon. And then gamma-linolenic acid and gamma-linoleic acid, whatever. That's two essential fatty acids that are necessary for tissue development, growth, stability. MS patients should eat both of those as well because those are largely involved in myelin production. Those two essential fatty acids are needed for myelin production. In RA, it helps with joint movement, omega-6, another fatty acid, omega-3, omega-6. So dietary supplementation, very helpful. And I show you the eating utensils so you don't have to grab, right? You can just slide your thumb through it and have you don't have to do fine motor finger movements. Okay, self-care deficit. We want to get them as much help as possible. You can use slide boards, you can use walkers, anything that can help them take care of themselves. Shower massages or adaptive devices in the tub, all kinds of stuff, right? They have walk-in tubs now, right? You don't have to step over. All right, all kinds of things. So, can we do surgery for RA? Yes and no. It's not going to treat the disease, right? I can't go, I'm going to do a synoviectomy and cure your disease. It's going to be the treatment of symptomatic problems where they've arisen, right? So we can do an arthroscopy. Let's take the little microscope on a tube and look in your joint, look around. Oh, look at all that joint disruption and these ruptured bursa and the synovial fluid changes, and I see pannus. You have RA. In an arthroscopy, we can sometimes clean up. We can take off bone spurs and shave down rough edges, take out scar tissue. So that sometimes can help relieve some problems. Osteotomy is when we fuse two bones together so they're not going to move anymore. It's going to stop the pain of the joint, right? Because it's not going to move anymore. It's also going to make it harder to do certain things, right? You're not going to bend the way you used to. Synovectomy, we're going to actually remove the joint linings to help some patients. And then a joint replacement, a hip replacement, a knee replacement, a shoulder replacement. Shoulder not as much because with RA it's knees more often than shoulders. Starts with the fingers, ankles, toes, fingers, wrists, toes, ankles, can move to knees and hips. If we have enlarged joints and we end up needing a joint replacement, we can do it. We also do that for arthritis, right? Or from broken bones and damage. It's nice if we can do it earlier. The average joint replacement lasts about 20 years. So if you get one when you're 40, because you've had RA for 20 years, because you got it when you're 20, are you likely to have another one? If we've done well with managing your life and your care, we hope you live long enough to need another one, right? So if you get one at 60, you might live to be past 80 now, right? You might need even another one. So it can be problematic, but let's see. We really want people, it's a lot of times we will kind of wait until you're far enough along, but you can wait too long with joint destruction, because then if you have enough osteoporosis and bone damage around that joint, it won't take the joint. There's nothing to attach it to. So it's a fine game that the physician plays with the patient about how far do we let the destruction get before we start replacing stuff. All right, medications. We talked about NSAIDs before. DMARDs, disease-modifying treatments. That's what the DM is. Anti-rheumatoid disease, whatever. Biologic response modifiers. That DMARDs modify the disease. Change the affected, they actually work on what the causative agent, the inflammatory process of the disease. The biologic response modifiers work on our bodies, and when we say, oh, we're having this happen because of the disease, our body responds to that. And so the biologic response modifiers change our response to the disease. Did you have erythropoietin on your list of drugs? Not this semester. Did you have it last semester?
Yes.
Maybe
You learned it last
you learned it last semester when you were doing kidney problems, right? And I think you did. You had renal failure or a little bit of chronic renal failure last time? Okay. You know the EPO's made, erythropoietin's made in the kidneys to stimulate red cells, right? So it's also, we can give it as a drug. So if your patient's got Felties, which is giving them anemia, right? We can give them erythropoietin to stimulate their kidneys to make more red cells to combat the anemia. See, that's different than an anti-inflammatory, which is directly attacking the inflammation of our right? It's just a moot point, but you'll see both terms in the literature, and so it's like, okay, I know what the difference is. Yeah, I mean, it's like, I don't know, they're all used to treat the same thing, so at least you know what it is. And then a corticosteroid. A corticosteroid, you know what that is. It acts like cortisol. It decreases inflammation. Naturally produced by your body. We give you a lot of it artificially. All right. Analgesics. You have to be careful. A lot of patients are allergic to aspirin. Aspirin allergies are a real thing. And if somebody has it, there's some of these disease-modifying treatments that also are aspirin-based. So we have to kind of watch our aspirin problems. If somebody's taking a lot of aspirin or NSAIDs, because aspirin is a non-steroidal anti-inflammatory, what are the side effects of those we have to really watch for? GI bleed. If they take Tylenol for pain, that's going to treat pain, not inflammation. So during a flare, NSAIDs. In between, when you're not acutely inflamed, could you take Tylenol for pain? Absolutely. So you mix it up, right? So what's Tylenol? What body organs can be affected by Tylenol? The liver. So acetaminophen affects your liver. Do you know what the antidote for Tylenol is? Mucomyst. Very good. So it's key things I just like to throw in there occasionally. Okay, we can give narcotics with two commas for some reason, but if we give narcotics, we're worried right now in this country about the opioid crisis, right? So we're much more cautious about when and how we prescribe opioids, especially the chronically ill. We actually have better long-acting anti-inflammatory drugs that will probably work better with pain management than taking one of the long-acting opioids. Oh, let's see.
What did you say? Which one was the long-acting?
Oh, we have.
Oh, you're just talking
Yeah,
about
I just said in
Steam
general. Yeah.
release stuff.
Yeah. All right. So non-steroidal anti-inflammatories: aspirin, ibuprofen, naproxen. Over the counter, first line, taken for 4 to 6 weeks during an acute flare. They're the least powerful, but if they work, they also have the least complications and other problems, right? So if that's enough to hold them, great. And we do have to watch for the toxic effects, the bleeds, the whatever. All right. They don't control the disease. If we're giving them a lot of salicylate products, salicylate, aspirin, acetylsalicylic acid, generic name of aspirin, right? But we'd like to give you enteric-coated tablets. That's going to diminish the GI bleed thing, right? What does buffered aspirin do? Does that stop a GI bleed? It doesn't actually. It does? Buffered aspirin is no protection against ulcers. Does buffering? Okay. Well, see, it's on the slide because I wanted to make a point, right? I'm not reading my slides here. I'm trying to do some of it without notes. It doesn't protect against ulcers. Buffering changes absorption time. That's what it does. And so people are like, oh, I want buffering because it's buffered, and they think that's going to protect from GI bleed. It doesn't. It just changes the absorption time. All right. And the GI bleeds are the highest with these. And that's NSAID, which is a trade name of some weird drug. Feldene and Indocin. Those are all trade names. I'm sorry, I should have been generics. Okay. You don't have to know that. It's not going to be on the test. You just need to know some are higher risk for bleeds than others, and so you want to weigh that risk. Blocking NSAIDs, also non-steroidal anti-inflammatories, block prostaglandin. That's how, one of the big ways they reduce pain, block inflammation, block prostaglandin. They're anti-prostaglandin agents. All right. Pain from RA, greatest during the night, and the stiffness and the severity on awakening is when they see the most symptoms. So take your dinner, then have your NSAID on a full stomach. It's going to be working as you sleep. It's supposed to help. Capable of damaging mucus layer. Yeah, you know what GI bleeds. Done that before. Okay, the disease-modifying drugs. Disease-modifying drugs. Methotrexate, sulfasalazine. Oh, we saw Plaquenil too. That was in lupus. Xeljanz. You've seen the commercials for that, right? It's a nib. But methotrexate, you're going to need to know methotrexate, not just in this unit, but in cancer. That drug's going to come up again. We've already talked about it. We talked about it a little bit in MS. It's an anti-cancer. It's a cancer chemotherapy agent. So it has a lot of those side effects that we're not real thrilled about, like red cell suppression, white cell suppression.
Is it immunosuppressant?
It immune suppresses. Big immune suppression. Kills your bone marrow. Kills your white cells. Kills your red cells. Sulfasalazine, I think we did that like last week, right? It was on a poster. There was a reason that was on a poster. I don't know what that reason was, but I'm sure you'll figure it out. The drug we talked about it with in our learning activity was, the disease was what? Inflammatory bowel disease. We talked about it with inflammatory bowel disease.
Is sulfasalazine, is that the trade name?
This is trade name. That's generic. I flipped them. This is generic, this is trade. Sorry.
Thank you.
Plaquenil's trade, that's generic. I had a mental moment that was dysfunctional.
Aren't the generic usually longer words?
Almost always, and they have the cute suffixes we like so well. Gold. There are people with rheumatoid arthritis who get gold injections. It's not like they melt down their wedding rings. There's actually a medical gold that is injected into their muscle, and it has anti-inflammatory properties.
How often do they use those?
Not very often, and more in Mexico than they do in the States. A lot of patients will go south of the border to get the treatment. Yeah.
So a friend of mine, she's from Brazil, and her mom has RA, and she gets ozone injected into her.
She gets gold?
Ozone.
Oh, ozone.
That's
Antioxidant.
antioxidant. Yeah, that's what we were
An antioxidant. That's interesting. I'm not sure we do that here. I've never heard of it
have
here.
ozone treatment here.
Huh?
They have ozone treatment here, but it's like a cracker.
But it's in other places. And is it injected ozone?
Yes.
Interesting. More to come, right? Does it work? That's the
Yes.
key.
She says it's my supplement.
She says it works. Interesting, right? Okay. With the biologic response modifiers, we talked about these two, right? You saw these two last week. So what do you think you need to know on this list? Remicade, Humira. They're the same knobs, right? We're going to talk about SEPs, Enbrel, SEPs. We're talking about that here. We're going to talk about ulcerative colitis. That is another common drug. We give the CEPT, C-E-P-T. They are biologic response modifiers that block inflammation. So look for that suffix as well. They bind TNF, they don't get rid of TNF, so they work a little differently, right? These are TNF antagonists, inhibits the secretion of it. This binds it so it can't do its thing. That's why it's a different category. But CEPT, Enbrel. Okay, you've seen commercials probably for Enbrel too. I mean, they were real big for a while. There's a couple of CEPT drugs out there. All right, but these are injections, so you're going to have site reactions. We talked about that before, so that's going to hurt. And then because they drop your immune response, you become at risk for infection. Sepsis is a big problem if you're at risk for infection, right? Mm-hmm. Urinary tract infection is the most common cause of sepsis in our country. Who's most at risk for urinary tract infections? Immune suppressed elderly women. Who has RA? Immune suppressed elderly women. It's such a joy. I represent that group. All right. Okay. I am not going to test you. Does nursing care involve teaching assessment and watching for depression? You're going to figure that out all by yourself. Okay. Well, okay. Glucocorticoids. We've talked about steroids already. I can't get away from my steroid talk. It'll come up over and over. But stops inflammation. Remember, if you stop it fast, you have to have the taper dose, right? Because it shuts your adrenal glands down. Adrenal glands work like a thermostat. So if you have a lot of something, it's not going to produce it. So I'm taking high doses of steroids. My adrenals are going, no, I'm taking a break. And so then when you stop the steroids, you have to have daily steroids secreted. So it's going to take a couple days to kickstart your adrenal glands again. So that's why we taper off. So the adrenal gland goes, oh wait, I'm waking up, let me get started, let me come back slowly, right? Again, moon face, buffalo hump, loss of proteins on your bones, gynecomastia, face hair, it's gluconeogenic, keeps you awake, causes psychosis, mood swings. We love steroids though. Okay. So early treatment is the best thing we can do for RA, because if we treat the inflammation early, we stop the joint destruction over the long term, right? So get on treatment, stay on treatment, do what you're supposed to do is your best chance for an optimal outcome. Like that's pretty standard, right? Mm-hmm. Okay. So if your patient's on the two that I told you had to know that are bolded, I'm really trying here. You guys keep going. What drugs do we have to know? I'm really trying. They decrease hemoglobin. They cause hypertension. That doesn't mean you don't have to know any other drugs in your nursing career, right? Mm-hmm. But when you go to work on a specific unit, there's going to be standard drugs you give all the time on that unit. You're going to get so good at that drug, and then those drugs, and you get pulled to another unit. And you're like, wait, all these foreign meds. But in your computer-generated charting, most of the time there's lexicon, right, or something similar. So I'm not saying you have to memorize all your drugs, but I want to make sure you have the emotional and professional intelligence and integrity to always look up your drugs before you give them if you don't know them, right? You've heard that before, but I can't help it. I have all these soapboxes I get on through the course of the year. You're going to hear a big one this afternoon. Hemoglobin, hypertension, headache, dizziness, drowsiness, and flu-like symptoms. Big ones for those diseases. Why am I not focusing on MAB? Because they're the same thing. Okay? CEPT. Wait a minute. This is the one that's bolded. It's a CEPT, right? What a coincidence. Oh, it binds to your TNF. And injection site reaction, heart failure, infections, and bleeding. I should have a comma. I'm sorry. I had two commas in the opioid zone. That's where it belongs. I just put it on the wrong slide. All right. Methotrexate. Wait. I told you you'd hear that one again. And on this slide, it's bolded. Methotrexate is bone suppressant. Methotrexate is a cancer chemotherapy. It kills rapidly dividing cells. It's immune suppressant. Rapidly dividing cells are your bone marrow, right? Red cells, white cells, and platelets are probably going to be suppressed if you're on methotrexate. It's also going to cause mouth ulcers. The mucous membranes in your mouth, rapidly dividing. Hair cells that grow hair, rapidly dividing cells, right? But we grow a lot of hair. It grows a lot faster than, I was going to say my hips, but that's not necessarily true. It grows a lot faster than my heart or my lungs, right? Okay? And it causes bad nausea and vomiting. Doesn't cancer chemotherapy generally eventually associate that with nausea and vomiting? Again, mucous membranes in your stomach, it affects your hematogenic centers. Okay, parenteral gold injections. It's not bolded, but it always has a lot of interest. And patients will ask you about this because they hear about it. It's been around for a long, long time. It was very popular in the 60s and 70s in our country. It ceased its popularity because of the mobs. We figured out what TNF was, and we started treating PAWS. And so this has fallen out of favor, but because it can cause damage to your kidneys, stomatitis, skin rashes, and mauve. What color is mauve? Like a purpley colored skin discoloration. Who wants to be purple? Right? I think it's a good color. We know glucocorticoids and NSAIDs. All right, so alternative medicines. Patients who are in pain, chronically ill, are going to use these. We talked about that with lupus. Some of them are harmless, unless you say, I'm not taking my MAB because I'm going to do this instead, right? But in conjunction with the other thing, harmless and may very well help your patient. These are things that give us concern because they give our patients bad side effects, okay? But acupuncture has a lot of favor. It really helps with pain. Again, works on the gate therapy like the TENS unit does. It stimulates pain over here so you don't know what's coming from over here. Therapeutic touch. There is a whole nursing theorist. I know we've talked about, I said we were going to talk about theory. I've got that on my schedule though, but I'm going to throw one in right here. There is a theorist called Martha Rogers. You don't have to know her. She's an interesting character. She created her nursing theory out of her love of science fiction. Isn't that interesting? But she was the nursing theorist who developed a whole theory on therapeutic touch. And therapeutic touch, we know touch helps people. But she also has, like, you can run your hands into their aura and you can feel bald spots and bulging spots and determine what their diseases are. She's got whole books written on this. It's really interesting. And there are people who swear by it. I'm not going to tell you that I have followed that theoretical practice, but I'm telling you I find it fascinating, and the people that have, a lot of them swear it works. So I'm not going to say it doesn't work. I'm going to say I've not used it enough to have an authoritative opinion on the subject, right? But therapeutic touch does help people. Touch binds us as people, right? And some people find comfort through touch. Some people are creeped out by it, so always ask your patient, right? You don't be touching me. All right. Hypnosis. Hypnosis with weight loss, smoking cessation. We know it works. And if it can cause you to respond differently in different situations, then there's a purpose and a use that people have for it. Cognitive behavioral therapy. I kind of like cognitive behavior. I like cognitive therapy in general. I'm a nuts and bolts kind of thinking girl. And there's a whole theory in psych out there that says a lot of your psychological problems is because you're thinking bad. Right? Cognitive therapy. You say, well, I always do it wrong. I'm always bad. Are you always bad?
No.
Do you ever do anything right? Of course you got it, Caroline. Of course you do. So, are you always wrong? Right? No. So no pity parties allowed. Straighten out your cognitive thinking and start thinking straight, right? So there is a cognitive behavioral. There's a cognitive behavioral therapist here that says there's cognitive behavioral therapy that works with the pain and the disease management of RA, so they don't go down the mood, depression, self-esteem spiral. So it's supposed to tighten help. Relaxation methods, biofeedback, hydrotherapy, soaps, water. Water is very healing. Magnet therapy, totally fascinating, right? Magnets are found to be very helpful for people with autoimmune disease. There's a lot of patients, an MRI is huge magnets exerting this magnetic field that we use in the MRI. So a lot of patients with autoimmune disease that say when they come out of their MRIs, they feel better for a few months. Isn't that interesting? There's a lot of magnet therapy going. We're going to talk about in NASDAQ. We have magnet therapy for depression now, and it's FDA approved. It works. Yeah. Anyway, so those we know, they're harmless, they very well may help, there's a lot of evidence being supported of them. What we don't is for people to go and look through some herbal store and find some quackery like this oil of the root of the orchid from South Brazil is guaranteed to cure your RA, so take it instead of your meds. I'm a little more skeptical, right? So a lot of patients are using Thunder Godvine. I have no idea what it does, but it's the most commonly used herb for RA. Huh? Well, that's not good. So if you're a 20 to 40-year-old, you know. All right. We know our omega-3s are important for our cold water fish, salmon and tuna, A, C, and E for their antioxidant properties. I know it's repetitive, but you know what? You're going to know it when you walk out the door, right? All right. So our expected outcome, don't hurt, keep moving. I'm sorry. I could read all of them to you. Don't hurt, keep moving. Do all the things we just talked about. All right. Don't be tired. Take care of the pain to take care of the fatigue. Rest adequately. Time management. I said that more than once. I think that's going to come up again. All right. So with our meds, they need to know their side effects and complications and be able to report them, right? That's a really, with these meds, there's a lot of them. And they can be very dangerous side effects. So at the first sign of infection, report it to your doctor. If you notice that you are pale or bleeding more than usual, then your anemia and your platelets may be messed up. Call somebody to get it. Don't wait until you are in a car accident and hemorrhaging a lot to figure out your platelets are low. Okay, so teach them. Lots of drug side effects that they have to be aware of. We did some of those, though. All right, how do we know if their drugs work? If the patient goes into remission and doesn't have exacerbations. That's how we know if their drugs are working. That's the best way to know. So if the patient's going months and months without an exacerbation, we've done good. All right, so this is all the stuff to teach, which I have now said 73 times. I'm sorry, I have. A couple of new ones. How to gain access to these therapies. You can't go to Walmart and get them at the pharmacy counter. These drugs are specialty drugs from specialty prescription pharmacies. So there's going to take case manager or the nurse who's in the clinic has to work with the insurance company and with the specialty pharmacies to get approval of these drugs. Remember what I said about costs? They're incredibly expensive, so it takes accurate documentation and making sure all the right boxes are checked to get the insurance companies to approve them. Nurses facilitate that for our patients. So helping them know how to get a hold of this and work with their insurance companies to make that happen. How to use an injection device. A lot of patients aren't good at self-injecting, so we have like the insulin auto-injectors and things. We have those for all of these biologic therapies that are sub-Q. You can get an auto-injector for them they just push the button and it gives the thing. So they need to learn how to use the equipment. They need to learn their schedule. They need to know what medications they can and can't take. Biologic modifying agents sometimes require you take a certain vitamin with it or something that treats one of the side effects simultaneously. And if they're on a medicine like that, we actually in TB is the only place we talked about that last week. It was B6 was which drug?
INH.
INH. See, look at you guys. You're rocking.
Oh, he's so smart.
He wrote that on he's the one who wrote it on the poster, probably. Or read it on the poster.
I read it.
All right. Knowing their support meds. If I'm auto-injecting at home, can I just throw my sub-Q syringe in the trash for the trash collector to stab himself on? Probably should be. Or you can, but we don't recommend it. So we send red boxes, the plastic bags. What can they use instead of that if they don't have one?
Hard plastic.
Empty milk carton, empty cleaning, like if you empty out the Lysol, you can throw your syringes in that, right? Anything that is not going to poke through.
Insurance will pay for sure.
Our insurance, if you got the injectable meds, it'll pay for the containers to be sent once every 3 months, whatever you like. Assistive devices, pain management, hot cold. We talked about hot cold. All right. Support groups. That was the last one on the previous list. We do refer patients to support groups. Patients help people that are newly diagnosed. Support groups help patients that are newly diagnosed because it's now I'm not alone. I have questions about what to do with my disease, and you're living with it. How did you handle that? Right? So it gives you that great network, shared experience. They no longer feel socially isolated. They have a group they can reach out to that understands what they're going through. Because their best friend for the last 20 years, who's still going out and doing everything that they've always done, that they can't do any longer, is going to be really nice and supportive. But sometimes it's nice to have somebody else who's had to give up the same stuff you had to give up. Right? It helps them with their diagnosis. So support groups are great for this stuff. For a nurse, the family members of the nurse, if they need something here, they need to seek professional help, right? They shouldn't go and talk. I mean, you can talk about your family issues in your support group, but if you need family counseling or if there's something on in your family, healthcare professionals better trained for that. If you're having extreme anxiety and mood problems, the support group, we need to help a little bit, but you really need a trained health professional to deal with that, right? So this is the kind of stuff we do that a support group can't do as well. All right, so we talked about the referrals all the way along, home health, if they're having trouble taking care of their ADLs, PTOT, pain management clinics, and counselors. And that's the end of Wonderful RN.